I'm glad to be here again, and I'm trying to present this really for all ophthalmologists, and sometimes I present it also to non-ophthalmologists because of important point that we can encounter with these problems. So our aim of presentation is humbly to share with you a series of KKESH, KFSH, patients with craniofacial disorders who were managed at the ophthalmology department. For the associated manifestations, we will mainly focus on the lacrimal drainage system, and the eye abnormalities and the eyelid abnormalities will come as we encounter them. So craniofacial disorders is the failure of the normal process of growth and fusion of the embryonic facial primordia. And we start very early to get this. The frontonasal process, the maxillary process, and the mandibular prominences, these are the three areas that can be involved in this problem, really. And the main reason for this is the abnormality in the migratory neural crest cells. This is the main area. So at one time, I was thinking, why should we call these things cleft? Why don't we call them neurocrestopathy? Neurocrestopathy, for example, because they have joint features. But then what makes the neural crest go wrong? You'll find that in certain diseases, completely different from each other, the same change happen in the encountered patient. So neural crest itself becomes abnormal due to different diseases and genetic abnormalities that can make them all come under neurocrestopathy and other abnormalities. So maybe in the future we will have different classifications. Now, a wide variety of congenital and anatomical disruptions occur extending outward from the oral cavity with varying frequencies and association with other congenital anomalies. This is the normal. Everybody probably knows it. We are all ophthalmologists. We have the lacrimal gland. The tears go to the punctum and the upper and lower lid, and then to the canaliculi. And it goes to the lacrimal sac. And here ends the orbit. Then we start the nasal part of the nasolacrimal duct. This is an important point to remember. At the end of the lacrimal sac, the orbit ends. Now we talk about cheek. Now we are going to get the involvement of the clefting, and you have the abnormalities that I will speak about. Now, we have to go a little bit embryology here. The frontonasal process from the brain, it grows down until the columella, anteriorly, okay? The mandibular goes from the sides forward, the maxillary, the mandibular from in the lower part. Between the maxillary and the frontonasal process, the surface ectoderm gets buried inside and start to form cords. Cord of surface ectoderm that's coming from the frontonasal process, it will form the lacrimal sac, and then another cord will form from the lower part, goes up, and then they will make the nasolacrimal duct. So please remember this very important point. The nasolacrimal duct doesn't grow from one area as a whole. The lacrimal sac grows from the frontonasal process, and the nasal part of the nasolacrimal duct grows from the horizontal cleavage of the maxillary sinus with the lateral nasal process. Okay? Now, all of this, what we're talking about, is derived from the migratory cranial neural crest cells. And if you look at the neural crest cells, in the very beginning, they will be formed and will go all the way until the lower part of the spinal column, the spinal cord, neurologically. So you will have neurocrestopathies that affect all of these structures as you go. We are talking only about the upper part. So Takahashi demonstrated in 2013 that for the first time that the ALX1, it's one of the very important regulating structures that regulate the migration of the cranial neural crest cells. This migration, they are formed and then they migrate. The signaling, the migration, everything about the neurocrest cells can, if it's disturbed, can lead to a different kind of a problem. What will disturb it is different kind of diseases, okay? Now, as I mentioned, the entire lacrimal apparatus is going to be formed from the surface ectoderm, as I mentioned to you, from below the nose upwards and from above downwards. This is only a picture to show in the beginning, you have the frontonasal process. This is 5 weeks. You have the eye pit, you have the nasal pit. The nasal pit has two parts on each side, lateral nasal process and medial nasal process. You see that they come together to form the nose until the columella. The lateral part of the nasal process forms the remaining of the nose. So even the nose, it has two different parts. This is the maxillary process, and in between here comes the ectoderm that forms the nasolacrimal duct. This is a cadaver, the eye, the nose, and you can see the Bowman's probe is in the common canaliculus coming to the nasal cavity under the inferior turbinate. Now, the other point is about the canalization. People have spoken about the canalization. It starts from the punctum, goes all the way down to the Hasner valve. No, the truth is, was found by many dissections that was done in this study. They found that the canalization happens actually, what happened here? Okay, can you please, maybe I touched something? Okay, the canalization does happen, I'm sorry. It happens in all of the parts at the same time, okay? But the last one is the valve of Hasner. But canalization starts at the canaliculus, at the lacrimal sac, and at the nasolacrimal duct about the same time, but the final part at all is the valve of Hasner. We will speak about problems that with eyes are spared, like this patient, for example. He came to us with bilateral, status post bilateral cleft lip and palate repair. You can see that the nose has also elevated eyelid. This is very common with the cleft patients. But he came to us with bilateral tearing and conjunctivitis, dacryocystitis really it ended up being. Having bilateral abnormalities in this area gave this patient the absence of the nasal part of the nasolacrimal duct. So we treated the dacryocystitis, and we always like to do this thing. This is the important thing that I want you to remember. Any patient you see with a cleft, don't say, okay, I will take him, I'll do probing, this is a child. Please don't, because you will not find any normal anatomy to go and do probing. Then you have another anesthesia for CT and another anesthesia for the proper surgery. That's not right. From the beginning, if you see a cleft, please go ahead and order this one, CT-DCG examination. Now, CT-DCG means CT scan with dacryocystogram. This one, actually, I was working with our neurologist, with radiologists, and I asked them, what can we, how can we do the examination of the lacrimal soft tissue? We want to inject the dye. They advised me to use a very diluted amount of the regular contrast they use for IV and inject it in the lacrimal system. I did that, and I left the patient, and the CT was not elongated at all because of my procedure. I inject it and make sure nothing stays in the conjunctiva by washing it, and leave, and then they take the CT scan picture and show us where the contrast stays. Contrast in open passages will never be seen because it will pass down to the nasopharynx. But in our cases, this is what happened. When I injected, the contrast stayed in the lacrimal sac only. Nothing went to the nasal cavity. And you can see the abnormality of the nose. This is not a normal nose. You don't see the three turbinates and concha and all of the other structures. It stayed only here. And if you look, the ethmoid is connected with very much with the nose, better than the nasolacrimal cavity, the nasolacrimal sac, I mean. And in the face of the lacrimal sac, you have bone that has never connected with anything below. Also, you have a suggestion of inferior turbinate that's not connected with anything. And the palate has been repaired. So they have deranged anatomy. For us, what we care about, is there any obstruction in the lacrimal system or there isn't, because we want to treat it. So what we care about is this. It never went, so I know that he has a lacrimal sac, but he doesn't have a nasal part. I went and I did for him bilateral DCR and everything went fine. That's the same one. He has non-coalescence. There's nothing that to coalesce with from the lacrimal sac downward. So he's a typical cleft patient with foramen cecum. After our treatment, he stabilized and went back to them. So there are many things mentioned in literature about the causes of cleft. I will not go through them because I'm not a medical, but we know that anticonvulsants and steroids can lead to this, to any cause of the and steroids also. Then we'll speak about the oblique facial clefts, and these can involve the eyes, the nose, and the mouth, and can be very complicated, and also can be very simple. There might be a very simple, small hint of this, or a very ugly picture that you'll be, I will show you some of them. At this time, von Kalmus has spoken about, described these oblique facial clefts, but then this year, sometime in late 90s, he proposed, or three quarters, he proposed this classification with the 14 lines of oblique facial cleft for easier clinical description and communication. Okay? Simply. If you look, you can find these clefts in the drawing. We have median, we have these 4 groups basically. Midline cleft is the one. Paramedian cleft is like number 3 and 4. They go from the mouth, like cleft lip, cleft palate, and then go involve the lower lid and the upper lid maybe. And that's where we get, involved in the lacrimal system and in the eyelid. And then you have also the lateral cleft. This goes from the mouth out and like that. We see this in the patients we treat, but we deal only with what we have to do. This is a little boy that was referred to us from the plastic department, general plastic, after they have repaired for him his right cleft palate, and he has this abnormality. You can see that the nose is elevated, the ala, and you can see a band going to the lower lid, dividing it almost full thickness, and it's attached to the globe as well. At that time, we knew also that he had the repair of cleft 7, which comes out from the mouth outwards, and he had the repair of left cleft palate. So left cleft palate, left cleft 7 of Tessier, right cleft lip, and this situation. This situation is, as what's happening here, this is called Tessier 3 cleft. Now, whatever it is called, this is something that you will encounter as an ophthalmologist. For us, this is the first time we see a band that attaches to the cornea as well. But because this is Tessier 3, it is known to have a combination with many other syndromes usually. When it happens, it has multiple than one syndrome happening to the patient, and also multiple clefts. So this is a series of patients with Tessier syndrome that just to show that they are involved with other problems. For example, this is association with Tessier 7. Only one was reported. Maybe our patient is number 2. God knows after this what was published in that. But in general, it tends to be associated with other abnormalities. It tends to be associated, for example, with lid colobomas, microblepharia. You have also abnormal nasal situation with extrophy of the nasal tissues, and non-development of the nasolacrimal duct, just like others that I mentioned. So our plan was to, treat this patient in staged way. So if you want, this corneal band is affecting the patient eye movement, and we have to, as usual, do CT scan to see what's happening, and also DCG CT. We did for him, and we found that definitely there was no nasal part, and this is the dye sitting in the lacrimal duct. If you want to reconstruct something that's attached to the cornea, we cannot do the two together. We have to get rid of the infection that is always there and is chronic, and then we will tackle the cornea, because you cannot have corneal surgery and at the same time a source of infection from the lacrimal sac. So we ended up doing for him DCR initially, and that's the sign of the DCR. And after that, we did his corneal repair. But I want to tell you about the DCR in these patients, which is really important, because also when you do a DCR in children, it's different from adults. In this patient, he had only one punctum, I'm sorry. He had only one punctum, so we put this stent in the punctum after we did the DCR. But what's important about DCR in children is that children are growing. They have the bones growth is very, very fast. And if you don't do a good osteotomy and you don't line it with flaps of mucosa, simply they will close that osteotomy. So you want to do an excellent DCR. Excellent DCR is, I'm afraid, is going to be only by external approach. I haven't seen anything that can reach to the size of the osteotomy that I require in this situation other than external approach. Endoscopically, I don't think you'll be able to reach that size of an osteotomy. In children, especially, they are very tiny. And you do external approach and you do your osteotomy, and at the same time, you have to put a stent so you make sure that the passages are going to be working later on. This is the monocanalicular stent that I used in this patient because he had only one punctum. You cannot put the usual Goober stent from the upper and lower punctum down to the nasal cavity. You have to use the monocanalicular. And we have a company here that we were able to get this one from. It has only one end, and the other end sits on the punctum like a plug. So it will do the job for us in the lacrimal system, and it's only one end of canaliculus for monocanalicular situations. Can be also used in the repair of trauma. It's called FCI, no interest, but this is the only one that does that. We did for him the CT, and we found that it was very important. We know that he has got no development, but also I'm going to operate and cut that tissue. I want to know how deep it is, what are the extents. It doesn't only show me the obstruction, it showed me also the other abnormalities, which are important. And in here, we can see that that band that he has reached all the way to the bone. And it is actually a deep structure that I have to remove. It's not a simple thing that I have to remove from the skin of the patient, okay? You can see the band here. And also this patient has posterior choanal atresia and abnormal nasal cavity associated with the absence of the lower part of the nasolacrimal duct. So what we did after the DCR, we became anterior segment surgeons, and we used the Grease Harbor knife to do superficial keratectomy. And then after that, cutting the band from the conjunctiva made us reach the fornix, and we had to remove the skin in a fresh way at the edges so that we do good primary repair of the edges of the eyelid, and we had to dig all the way to the bone to remove this band, okay? After that, you will follow the band as deep as it reached. At the lid margin, I said we will freshen it as well. And then when you treat the lid margin, it's just like the usual, and everybody does anterior, middle, and posterior sutures to have a good approximation of the edges and leave the sutures long so that it doesn't rub against the cornea. In the situation that you have a normal conjunctiva, you're going to put bandage contact lens so it doesn't rub against the eyelid. But if in the case like in our patient, we lost our fornix because of this depth of going all the way down. At that time, you have to do a symbolophorone ring for fornicial reattachment after suturing it. This is the bandage contact lens. This is the symbolophorone ring. And our patient, after repair of the, before the repair actually, I repaired the fornix initially. Before the repair of the lid margin, I put my symbolophorone ring. Then I repaired my lid margin. And I repaired the fornix by reattaching the conjunctival fornix to the lower orbital rim using vicryl sutures. And this is the patient at the time of the removal of sutures and the symbolophorone ring. When we make these long sutures at the lid margin, we like to fix them by a tape or something. Really, even if it comes off, the patient cannot remove it. But it's nice to do this so it doesn't rub against the cornea. That's him after we finished. We can see that his lid is free completely from this scar on the cornea, but he still needs help because he was referred to the strabismologist because he has inability to move normally. He has cross fixation. If you ask him to look to the left, he only look with this one. He doesn't have the lateral If you ask him, he's looking to the right. So I think the strabismologist will take care of that point. I want to say that when in probing, we know that this is the area of obstruction. So if you easily go there and do it. But in our situation, this is in acquired, this is the area of obstruction. And in these children, this is the area, probably the area of non-coalescence or absence of the duct might be lower than that. But both of them are treated by DCR. When it is congenital and it is lower than that, you'll find a big lacrimal sac with a large mucous membrane area. If you do the flap only here, you still can accumulate things in the lower part and have infection. So in a congenital one, you really have to go with the lacrimal sac and cut it all the way down to where it ends. It ends here, you make the flap that big. Even if you will do the conduit, small one, open that lower part and make it unable to collect and reduce infection again. And this is the size of the osteotomy that you need to have. Osteotomy that's centered at the anterior lacrimal crest with at least 2.5 centimeter in children and 3 centimeters in the adults. And then you line it with the mucosa. My wound, I like to do it in extended DCR, doesn't mean necessarily disfigurement at all. And people speak about webbing and speak about ugly scars. I'm afraid it depends on what you do. You always want to do the good plastic procedure that give you the good result, no matter what. You're going to attack the skin for any other reasons, like upper lid crease or any other reason. So working on the skin is okay, but do it the right way. I like to do it in a oblique fashion, but most important for me is, I'm sorry, how does this happen? Most important thing for me is the way I close it. You have to have a nice cut, vertical on the skin. You knife anywhere when you cut in plastics. Your knife has to be not beveled. It has to be vertical on the skin so that you have a good edges. And then I like to do the everted edges repair by horizontal matrix sutures. When you evert the edges of the wound like that, and when you remove the sutures later on, it heals, it becomes flattened and very cosmetic. If you have it nice at the first day, it will heal and cause a scar, and then you will have a groove that you can see from 1 mile away. So think about the far, don't think about tomorrow or the patient, what will see the patient. I'll tell the patient it will not look nice today, but later on it will almost disappear. So I found this worked for me very nicely. And here, okay. This is one of my patients. You can see almost the scar is gone. And this is the tube. And about 4 months later, I was going to remove it at that time. And you can see there's no webbing. The scar is fainting, and it's not ugly at all. It's not grooved. This is in the beginning, post-op day, and this is like 4 months ago, afterwards. This is Goober stent that we use in the regular situation. This is another patient now with Tessier syndrome, that's number 4. Here you have really more damage. You can see that there is no lid closure at all. There is also very low, the eyelid has not been formed completely. You can see only part of it is here, and the lacrimal system is affected badly with this situation. As usual, we did for him the CT scan before we operate. I'll just show you this one, that when the patient is sleeping, the eye is completely open. And when he is looking down, the eye is completely open too. There is also in this patient, other than the Tessier for abnormality, there is also a shortening of the upper lid. It is definitely shorter than the right side. It doesn't go all the way down because of the abnormality at the angle. If the lid doesn't attach in the normal place, it doesn't continue to grow normally because of this clefting problem. So we had to tackle things that will make us preserve this eye, because already he has a corneal scar. Doing CT scan for him shows all the cleft abnormality and shows the lower level of the orbital rim. So we took him and we did for him surgery with the plastic surgeons. He doesn't have any lacrimal system up and down. So we did the surgery with the lacrimal, with the plastic surgeons. We did a flap for him from the nose and a tensile flap from the outer part to help protecting the eye. He did well, but eventually we were able to also now tackle the upper lid to protect the eye. We did for him levator recession and skin graft for the upper lid. Eventually, he will also need this. What is this? Jones tube, because he doesn't have a lacrimal system. As a child, we don't do it, but when he grows older, he can have a Jones tube placement. Now, these oblique clefts can present. I want to warn you that if you see any abnormality at the CANTHUS, please do a CT scan. The whole point about this is when you see abnormality, don't treat it like a regular situation. Just do a CT scan. This is only medial cancel depression in the left eye. And when we did the CT, we found that he has multiple abnormalities. He also have this band that's reaching there. The nasal cavity is narrow on this side. And he has got a very small lacrimal sac that's displaced. For him, we did the DCR with this, a big incision of the lacrimal sac, and then we knew that whatever we do, he might still have this depressed canthus, and he must still have tearing, but there's no infection. That's the important one for us, because he's also cardiac. We don't want to have a source of infection in his body. This is the worst situation that we encountered. I'm sorry. I should have warned you, but really, this is again a patient with cleft in the same area, mouth, nose, and medial side of the eye. And it is associated, which is cleft 3. We said that it's associated with many other problems. In this patient, it's associated with Goldenhar syndrome. When we see this patient the first time, it was really horrifying for all of us. And it was referred from the plastic surgery. As an ophthalmologist, what's the first thing that you want to do to this patient? Not kill her, طبعا. I'm sorry, I feel so sad for her. But we should really help the patient, okay? The first thing you want to do is to keep the vision. See how can you keep some vision in this patient. مش كده? That's the first thing you want to do. And when I saw her, I examined her under anesthesia, I found this tissue here is a dermolipoma that's attached only to the lower part of the cornea with detachment of the lower fornix. So I took her. The other eye was really different, but let us talk about the right eye. You can see the dermolipoma. I can pull it up, I can pull it down. So we went ahead and operated on her. But the left eye, under examination, showed also all these very, very difficult situations of coloboma of the lower lid, microblipharia, the lids are short, and she has got this growth of the skin, and she's got a part of the cornea that looks clear and it is adequate, but she cannot blink in that eye. So we removed this one, and we elected to take care of this one medically by lubricants until the patient grows and her skin becomes easy to make flaps and stuff. If you want to operate in the cornea, you have to have good lids before that. If you don't have good lids, don't touch it, because you're going to damage it. If you remove this and you cannot close the eyelids, that's very bad. Leave it, lubricate it, be conservative, moist chambers, teach the family, and then when the patient grows and you can do things with the skin which is easier to move, you can afford to help her. I do this night shots photograph to show me the pupils. In her right eye, you can see the pupil was free to some extent. Also in the left eye, you can see the pupil was free. She can see with both eyes. We followed this patient until she grew, and you can see the ocular motility. I was moving the light up, and she goes up, she goes down, but this eye is frozen. She doesn't move, it doesn't move, and it is exposed. We're sorry, we have to wait with conservative treatment. She grew, and they have joined the plastic surgeon, and she can close the eyes nicely. She can. The lag of thalamus was a little bit less because of the development of the tissues from below on up, and now we are scheduling her for a procedure because we can now help the lower lid and the upper lid can close already. This is her CT. This is a patient who was born with lid coloboma, and you can see that it was repaired, because the first thing you want to save in these children, even in the first week, is the cornea. So I repaired the lid coloboma on both sides, but I anticipate bilateral DCR due to the bilateral cleft that's high in level, and I know I will do a CT later on. It can be associated with lid abnormalities, very subtle, to tell you that this area is an oblique cleft. She has cleft palate that was repaired and cleft lip that was repaired, but the nasal part of the duct was intact. So it doesn't have to be always the same rule, but please do it anyway. We repaired the upper lid coloboma. You can see the coloboma is also in the lower lid, but it's not obvious. We only repaired the obvious one. And this is her after the repair. This is another child that shows only lid coloboma, but he shows all the other features of clefting somewhere else, but not the lip, not the palate. Repair the coloboma alone. And in this, what we do, we freshen the margins as well, and we do a tensile flap that's directed this way, so that we pull, directed this way to pull the lid medially. I want to tell you that when you see these colobomas, these patients have punctum and have canaliculus in this little part of the eyelid. So when you deal with it, when you see it, don't feel that it is terrible, you cannot do anything for it. I assure you, you can help these patients and they can become normal. Look for the punctum in the upper lid and the canaliculus, and cut lateral to it so you don't damage it, and freshen the edges and repair the coloboma. And please put a tube so you don't have any fibrosis in the repaired canaliculus. Did you have enough? Okay, that's my conclusion. Craniofacial clefts and other syndromes involving the midfacial growth can present with oculoplastic eyelids and lacrimal drainage abnormalities. The awareness of the possibilities of that we encounter is important, so that you can do the right investigation and predict what you need to do, and counsel very well with the family, because the family will need to know that this is a multi-stage repair. They might be in need of multiple surgeries in the future. If they don't understand that, it's very difficult for you to touch these patients, because they will tell you, you've done this, but you caused that. But you tell them, no, it's going to need multiple stages of repair, some now, some when the patient grows up, and they will help you when you make them understand. Thank you very much. Any question? Well, most of the families are already depressed from the minute the patient has been born, you know, and they have gone through the difficult part before referring to us. So I think it's very nice to sit and talk with the family and say, we sympathize with your situation. We know that this is, and thanks God we are Muslims. I'm sorry, I don't mean anything, but in our religion we have something very good, which is we accept what God gave us. And many people have this excellent faith in God's willing. And that helps us. And you know, we tell them that we know that this is happening. We like to help you. We sympathize with you. But we want you also to understand that this is going to be a multi-stage situation. And it's very good to have family genetic counseling for any problems that can be solved, especially now, for example, Treacher-Collins syndrome. People have reached a level of investigation that there is a hope that it can be prevented. So we tell them, we also refer, especially the problem is when the family, I tell you what I saw usually. I usually see the child with the grandmom, not with the parents, because the parents are devastated. They don't even come with the baby. This one, the last one, the very Goldenhar one, I saw her with her grandmom once and many times. After almost 1 year, I started seeing the father. I have never seen the mother. Yeah, very sad, sahih. But the thing is if she comes, I will talk to her. I talk to the grandmother, she's excellent. The father is also reasonable, but they need a lot of support and psychological counseling and all of that. Please.
Dr. Samir?
So, anesthesiologist, I want to know what was the challenge of sharing this space between
Yes.
the two, because I know that
Yes.
this kind of problems arise
Yes.
between the anesthesiologist and the surgeon.
Thank you. Thank you very much, because I didn't expect anesthesiologists to be with us here, but I really want to mention this point. These patients have difficult anesthesia. Most of them have tracheostomy already. They have stenosis. They have mid-facial hypoplasia that extends to the first and second branchial arches. Some of them have sleep apnea. They need ICU bed after finishing. So they are really tertiary care center patients. So you encounter all of these, yes. Yeah. It's a challenge, yes.
Yes, Dr. Samir?
Thank you, Dr. Amal, for this nice, interesting, challenging subject with good illustrations.
Welcome.
Actually, these cases are congenital, and I'm sure many of them are, the vision is disturbed during these stages. So how much amblyopia do you see, and do you collaborate with pediatric ophthalmologists?
Oh, yes. We collaborate, but I chose not to speak about that because, of course, we collaborate with them. My role is to give them a free pupil, a free access of vision. After that, if they have astigmatism, they're seen by the pediatric ophthalmologist. If they have all of the other problems, they have also fundoscopies and all of that. But my role is at the level of freeing the visual access from the lids and from the colobomas and for the lipodermoids and all of those ones. But definitely they are seen by the pediatric ophthalmologist.
How frequent do they have good vision after all these procedures?
I did not look into that, but anybody that you save his vision, like our Tessier 4, that we had to lengthen the upper lid, he was excellent in both eyes. He had a corneal scar that from before we saw him, which had started to faint after we did the lengthening of the upper lid and the grafting of the lower lid. And having no drainage of his tears, it was so nice that his tears was always lubricating his eye. Still, he needs ointment at bedtime. But we never looked at the assessment of the visual acuity, and this, from oculoplastic point of view, I want to mention the role that you can do to help them develop and prosper with the pediatric ophthalmologist. Huh? Yes, exactly. Our main is to keep what's there and let them not lose any of what they have.
Dr. Amal?
Yes,
Yeah, please.
please. Sorry.
With the lipidic contrast in the
No, not
cystograph, you have
repeatedly.
you have
Yeah, with the CT.
contrast
Yeah.
in the lacrimal system more than half an hour. I use this for the exam. It's very good. Not the liquid, the lipiodol.
No, I will not be able to tell you exactly what is being used. I'm not a radiologist, but I took the advice of what is the safest one. In our patients that we are injecting, and it doesn't go to be taken by mouth or to be ingested after if it passes away. That was my concern. Is it safe if it gets in the gut or not? It is a very diluted concentration. Really, I put only 1 cc on 5 cc's of saline, so that it's really, if you use it full strength, it's going to become absolutely not useful. It will make everything white. So you need to have a very diluted contrast that dissolves in water. I think it's non-lipid, and it is a small amount that you inject. And after you inject, you remove your cannula and wash the ocular surface from any other that sits there and make it useless. You have to be there and make good out of what you do. Thank you.
Dr. Amal, for the residents, can you explain for an eye that doesn't close how much lubrication they need, to preserve the cornea?
Thank you. I want to everybody who doesn't prescribe lubricants properly, leave his eye open for more than 8 seconds and see what will happen. It it will burn, he will tear. And the same thing happens to these kids and to any patients who's unconscious. Lubrication of the cornea is something very, very important. And if the best way to go to know, when a patient has a lagophthalmos, what is he lacking? He's lacking corneal lubrication and in danger of corneal ulcer and epithelial defect. He's lacking clearance of the ocular surface from the debris of the tear film. Tear film has lots of debris. If you put lubricants, they stay on the cornea. He cannot clear them because he does not close the eyelids together. So if you don't have this eyelid closure and the irrigation of the ocular surface, in addition to the lubrication, you're not really doing all what you can do. And the protection of the ocular surface. That's why we go for tarsorrhaphy to reduce the ocular surface. We go for irrigation of the ocular surface. Use excellent irrigation. You will remove infection, organisms, debris, and then put your lubrication. The lubrication is going to be drops and ointment. I've seen people putting 2-hourly ointment. For God's sake, ointment 2-hourly, it's too sticky, it will dry on the cornea. You put, what is this? It will keep organisms, can lead to, you have to wash it off. And then put the drops and then put the ointment. Every time you want to lubricate, ask for washing. And we have also the moist chamber that we can place on the eye. If there's no moist chamber, if the patient is not conscious, probably you can put also the occluder for the amblyopia on that eye. You tell the patient when you go to sleep, if the patient is awake, when you go to sleep, you should do this and that. Put it during the sleep with ointment. Do good ocular surface wash and lubrication, then ointment, and then cover it by a coverlet or by a moist chamber.
Okay, thank you very much, Dr. Amal, for this
Welcome.
excellent lecture.
It's my privilege to be here again. I love this place. I belong here. This is my home. Thank you so much.